Shirley Fenton, manager of the Infinite Project and one of your hosts today. And as in our previous events, I welcome you all to this very special presentation today. We have invited a panel to talk to us on smarter health, things that we've been exploring over the last few months. And we'd like to pause at this point before we adjourn for the summer, review maybe some of the major things that we have learned, reflect upon them, and bring some, hopefully some conclusions to our discussions. Before I introduce the panel, just a couple of items. We want to continue this exploration. We will do so starting again in September. So I will be sending out information probably late August to let you know what our series events will be. So keep an eye out for that. The second announcement is that we now have most of our previous seminars on our internet website. So if you haven't been able to be with us for our previous seminars, go to our website. You'll be able to not only see the PowerPoint presentations, but we also have the videotapes available for you to take a look at. So I invite you, if you haven't been able to join us, to go back to our website. Our panel members are Chris Bailey, lady in white. She's a board member, as well as many other things, a board member from the Grand River Hospital. Our next, I'm going to introduce them in the order for which they will be speaking. Our next member, our panelist, is Patricia Beretta. Patricia is Vice President of Marketing at Mitra. Beside her is Nick Sircone. Nick is a professor at the University of Waterloo, former chair of computer science. And our final panelist is Joe Laforet. Joe is Director of Information Services, St. Joseph's Healthcare. Now, I believe we're going to try to get everybody on the panel, every person on the panel, to have a mic. And that equipment is just arriving now. So let me first introduce to you then, while we're getting that equipment all set up, Dominic Covey. Dominic is the Director of the Education Program for Health Informatics Professionals, and he will start with some opening remarks and moderate this session. So please welcome Dominic Covey.
Maybe I'll stand over here to make it easy for our cameraman. I'll just make some general comments and maybe kick off a little bit of the exchange of information that will occur. I'm hoping the panelists not only will make statements, but will maybe do some battle back and forth, and we're trying to get everybody outfitted with microphones to make that easy. We covered a lot of topics here. One of my reasons for having this last session was to be able to learn as much as possible about how to do it better the next time. So in addition to comments on the topics we'll be talking about, if any of you have suggestions for topics next year, starting in September, or better ways of doing this, one idea that we've had would be to take certain of our sessions to some of the regional institutions and have the equivalent of a grand educational rounds at the regional institutions. If people are interested in that at their institutions, or we can have some here, some there, we're looking at different formats to get this kind of discussion, this kind of information as widely available as possible. So I welcome your comments either here at the session or as you get home and you have a chance with the email. I'm going to read you some recent newspaper articles that maybe will say that what we've been talking about this year has a great relevance. In May 31, Globe and Mail, there was a report of a study being done that was done by Richard Irving, a professor at York University, the Schulich School of Business. He did a study of Canadian hospitals and surveyed hospitals throughout Canada. I think he got about 100 responses, 100 and something responses to that. He's got a number of comments here that parallel closely with some of the topics we've covered. It says that Canadian hospitals are investing only half the amount needed to take advantage of the latest computerized systems. We talked about that, and that's been now. I was just at a meeting in Quebec City with some people who were here, and that came up there, that people are underinvesting in IT throughout the country. The biggest constraint that leads to that underinvestment is the availability of capital dollars. I happen to believe that's not entirely true. I think if we believed in our health system that IT really made a difference, and we had evidence that it made a difference, the dollars would flow better, and we're undertaking some steps in that regard. Some of the things he learned in surveying the institutions was that 25% of Canadian hospitals have been able to afford order entry systems. I think that number is actually high. I think Patricia might comment on this, that 25% of hospitals have true order entry by physicians, particularly. And order entry by clerical people is really not a good answer in the health system, because you can't remind clerical people that they should choose a different medication if the one that's ordered conflicts with the other medications the patient has. Among other technologies, just 15% of hospitals, that's 15% of hospitals in Canada, currently have electronic systems for managing diagnostic images. And we have a number of people here, experts in the area of picture archiving and communication systems. I'm sure they would agree those numbers are correct. I know the next figure. We have some portion of their records on electronic systems. They do not have full electronic health records, as we would call it. So that's misquoted, is probably the best way of saying it. This paper reports that 32%, double the number of people that have picture archiving and communication systems and diagnostic imaging, are going to have one next year. And if you believe that, I have a bridge to sell to you. Spending on computerized business and clinical systems, it claims, are 2.2% of the total operating budgets of Canadian hospitals. That's substantially above the CIHI estimates of 1.88 that were reported at the meeting in Quebec City. Here in the province, it's 1.6%. It says 15% of Canadian hospitals admitted to a serious breach of computer security. I'm sure that number is much higher from my own experience. There's one right on the line of the page here. It says that 1/3 of hospitals have neither a disaster recovery plan nor a continuity program. As you know, another word for disaster recovery is business continuity, so it's really the same thing. So 13% have no plans at all. 17% have no intentions of creating a program. That's interesting. At the time we live, if there are no disaster plans. All those who are in consultancy hear opportunities. Basically, it says that there must be a serious business case for systems, and sizable payback needs to be identified. It says about 30% of IT managers said that the chief executive officers in their hospitals currently lack an understanding of information technology. And it is not actually only the chief executive officers. We were this week developing a grant, a proposal for a grant, and it came to me as clear as St. Paul was spoken to. What's the major problem in our hospitals? And I can tell you absolutely it is human resources. I can tell you that unless we can address the human resources deficit within our hospitals, these numbers will be bad next year and the year after and the year after. Bad decisions are being made, either to fund systems or to choose particular systems. And something needs to be done about that. We're taking some steps. I hope others take steps as well. It points out here in this particular thing, I'm having trouble reading this stuff, Computer World Canada, that there's a huge, still a huge, even with all the failures of businesses, a huge deficit with respect to technical workers. It says that we're looking to fill in the technical field, not just in hospitals now, 38,000 IT jobs, 9,900 more than the available pool of workers. 60% of enterprises reported a measurable loss as a result of the IT skills shortage. Many other quotes in here that are of interest. I'll just give you a couple of them. 40% of graduates from universities and community colleges have found a job within a month of graduating. 68% within 90 days. That means we're picking them up out of here as quick as we can. In fact, we're having trouble keeping people in the programs from time to time. There is a brain drain to the United States. Now, the net is that the number of bodies in Canada stays relatively constant. What they found in the studies is the people who leave are the more senior people. So we have a brain drain among the more experienced and senior people, according to this particular survey and other surveys. Very, very interesting. People will leave their jobs, and I know this is true in hospitals because I deal with it all the time. It says on the order of, let's give you the actual numbers here, for a pay raise of 20% in their salary, 55% of Ontario technological workers will leave their job. 1/5 or 20% will leave for a 10% increase in their salaries. There's not huge job satisfaction. There's a huge retention problem out there. And what's happening is there's a huge churning going on. One of the reasons people leave their organizations, according to this particular survey, is because of a lack of training, and they call it murky career paths and poor change management. They don't know what to do or what their next job is. They're not properly being trained within their organizations. So how do you get trained? You change jobs and get a new job. If you put all this together, we have a big problem. And one of the great interests we have, obviously, is the education of people to make a difference here. I want to lead off with that saying, I believe the fundamental root problem we have is that human resources problem. I'll be curious as the panelists go on, maybe to comment on that. Thank you very much.
So with that very stimulating introduction, let us begin. So we'll start with Chris, please, and for your presentation.
All right. The only thing we didn't do when we went to prepare was to figure out how to use all the new technology. So, are we ready to go?
Yes.
Okay.
And the slideshow.
And the slideshow. Okay, I'm done.
How do we get to Chris's presentation?
On the bottom. Taskbar at the bottom.
Uh-huh.
Passport at the bottom? Okay. We don't know which one it is. Smart Health Panel.
Yep, that's me.
And then you need to hit the little projector thing.
Wow, it's not good. Well, it's very nice for me to be here today, and I certainly hope that I can be provide you with some insight from a board perspective. I'm on the board of directors of Grand River Hospital, and I'm also the chair of the Health Services Committee, and one of our mandates and requirements as not only a Health Services Committee, but also as a board member, is information technology. So what I'm going to do is I'm going to talk a little bit about the current state, the issues, consequences, some of the trends and strategies, the magnitude of the problem, some of the critical success factors, as well as what is believed that industry and academics can add value to a hospital scenario, and particularly to a board in terms of our deliberations around how we move forward. Because it's not easy. You get an awful lot of things that are given to you in terms of priorities, and which ones do you choose? So let's start with the current state. It is clear that within a community that we have a very fragmented system in terms of healthcare. None of these particular pieces or elements of healthcare today talk to each other. But patients move through each of these elements. And you know, a patient, when you start off, you're born in a hospital, you might be born at home, but over the course of your life, you go in and out of healthcare all the time. And your medical record does not. The only thing that moves through the system is your body, and nothing about you moves with you. So every time you go from one point to another, that needs to be repeated. So here's some of the issues. And my focus is largely on the information technology side, not on the whole system, or I would be here for a lot longer than 5 or 6 minutes. From a healthcare information technology, generally, it's fragmented and disconnected, and I'm talking about from the way it's actually implemented, not because the technology isn't available, it's because it's not connected. That these standards have been evolving pretty rapidly over the last decade. Inflexible old legacy systems that were paid for, built, and put in the 80s, and are still expected to work with some very brand new, very sophisticated, very mobile technologies, and sometimes it works and sometimes it doesn't. I'm glad I used the number of 2% because that's somewhere between the 1.88 and the 2%. But in general, IT accounts for very little. When you go to the banking industry, probably most of you know how much they invest, 8, 10, sometimes even 12% in the finance and accounting business. And yet we're in the business of information management, and we only invest 2% in those systems because there are so many competing demands within a hospital for money that that's all that has been put into the investment. Chronic disease is an interesting piece, and I threw it up here because I thought it was important for you to understand that up to 14% of the population has one or more chronic diseases. And of those chronic diseases, 70% of total health care dollars are spent on those. And they fall into only 5 categories: cardiovascular, cancer, diabetes, depression, and asthma. Now, all of those are with patients that largely stay at home. And then they get acute scenarios, and they go into a hospital, and they go home, and they go to clinics, and they're going back and forth. So if you go back to my first slide on fragmentation, the patient's moving back and forth with their chronic disease, but their information isn't. And consequently, a huge amount of duplication of effort is occurring in the system. The consumers are a heck of a lot more savvy than our institutions are. 50% of patients actually go on the internet and get health care information and cart it with them to the doctor. They might not know what it all means, but they take it with them. And they expect that their doctor has the same access to that level of information. And I have some interesting stories about patients who have AIDS who are pretty up on their diseases, and they go to their family GP and expect a pretty intensive dialogue, and they don't get it. So they've actually researched more. Their GP needs to know a lot, but not necessarily always at the same level. So we know that these consumers are getting a lot better. And the patients aren't happy with all this duplication of service. Pretty well every survey that's been done everywhere, the patients are not particularly enamored with the healthcare systems. Not only here in the city, but all across the world, it's pretty much the same story. Governments in general have very short views on things. They just want to be reelected for the most part. And consequently, there's not a long-term view. And health IT is a long-term view, because you're not going to get a payback in a year or 2 years. It takes a long time to see that. We don't have smart electronic health cards. There's no health information strategist either at the federal level or at the local levels. Patients are the recipients of the fragmentation. They get to move, but their information doesn't, nor do their caregivers. And there also is a fair bit of resistance in the professional organizations to change. They like it the way it is, and they don't often like a huge amount of disruption. And with health IT being such a great enabler, there can be a lot to be expected. So the consequences, I just kind of put them into 5 categories. First of all, cost. It costs more to run a fragmented, disconnected system. Consequently, sitting on a board and having to approve things, I know darn well that we are approving things that are very narrow viewpoints, narrow-minded, because we're looking at facility-based costs only and not looking at systemic costs. But we're talking about paper systems that are rampant, and I think PAC's discussion a little later may bring some of that to the forefront. Duplication of services. Multimedia integration. They don't bring the things of images, voice, text, and graphics all together in one place. So you might have some things that are electronic, some are paper, some are faxes, some are telephones, and the caregivers have to put it all together. It results in lack of clinical coherence. It's not easy to have your clinical programs sorted out properly in your institutions, so you end up duplicating them. The same thing with the support services. Patients have to go to the services. And for those who are very ill and who have been let out of hospital early and from surgeries and so on, it isn't easy for them to go to services. And they don't like it very much, and it's tiring and time-consuming. The patients often have to have things repeated as they go from one institution to another for care. And it's not always easy to manage that continuum. There's a poor utilization of scarce resources. 20 to 45% of the professionals in healthcare, net of retirement, are going to be out of the system in the next 5 to 10 years. So who's going to do the work? That's a big problem. how do we alleviate some of those other things so that indeed we can manage with fewer resources to manage patients, but also to find ways of attracting people. And I will tell you that the fragmentation and the poor decision making by management in healthcare is a lot of the reason why people aren't being attracted into the profession in the first place. So there needs to be some enablers for that to happen. The electronic patient record is more of a myth, it seems, than a reality. It's just in its early days. And I think at the end of the day, a lot of people would shoot me on this, but I think healthcare is somewhat fiscally irresponsible. Because of all those previous issues that I stated, we're spending money on things we shouldn't be. And there should be other places to spend money that have better payoffs, both in the short term and in the long term. The trends, quickly, genetics and new technologies are just simply going to take over from old methodology of caring for patients. And it's going to cost money, not only to actually have it in place, but it's got to be researched, the applications have to be understood and has to be implemented, and all that's going to cost money. Patients are more involved in their health care. They want to know and they want to be part of the solution. Data integration and data mining will be a part of the patient education process. And IT will be the enabler of the appropriate and timely access and transfer and updating of this information across the system. In the strategy side, there's been many studies completed over the years, but very recently in almost all the research that you read, that healthcare needs systems that are integrated, they're automated, they operate in real time, and can be updated anywhere. And I had a good example of a physician who works in this community, who has a cancer patient, who had his laptop with him, works on satellite, who has just recently gone on to PACS and was with a patient down in the emergency room who had his laptop with him, who was able to call in the tumor from before the operation and the tumor from after the operation, and was able to show that patient exactly what it was before, what it was after, and then was able to call up what the continuum of care would be for that patient from a clinical care protocol, and printed it off with his little portable printer so that patient could take it home. He was over the moon, and the patient was thrilled. Now that's an example. You see it happening, but it's very much the irregularity than it is the norm. The magnitude of change, well, I said before, there is a huge amount of different areas where patients end up in the clinical care axis. And when they're at home, patients want to participate more, and as they get more acute, it gets more complex. There's more interactivity. There's more need for consultation, which means distance things become much more important as you go down the zone of complexity. But also when we think about IT, we think about things in community care around the prevention, education, and curing. We have patients at home. We have patients in hospital. All those things you need to have access to that patient care record to do any of it. And I think about things in the long run of how you get to community care, and you start to look at communities as a whole and patients as many patients, so that you can look at surveillance and epidemiology over a larger population base. And without an IT data mining opportunity, that is impossible to do. And that's just a picture of, here's all the bits and pieces that need to get linked together, tied together. It's sort of just a simple view. But right now, if you think about all those things, they all stand alone. They all have their own systems. They're not linked. They don't talk to each other. And the only way they do is a paper transfer or the internet file transfers. So what are the critical success factors? Well, there's some way to tie these systems together. Have an integrated delivery of services for chronic disease will have a very long-term payoff. And some of the HMOs in the States have found through IT as being the key enabler and care protocols that they are reducing costs on their chronic care patients by up to 30%. So when you go back to those statistics and those numbers and those billions of dollars, there is the payoff there. There's been some pretty good studies done in the U.S. that indicate this. And I certainly think as a board person, we're going to have some big decisions to make, and they're probably not due into your future as we get closer and closer to these kinds of decisions. The physicians and caregivers are going to have to buy into this process, and that won't be an easy thing to do. The government in Canada, we have one-payer system, so reimbursement incentive schemes are important for places that do a good job and are able to link things together. We've got a baggage and a history of highly capitalized systems that may or may not be able to integrate easily. And the accountability and responsibility issues are there for data ownership and privacy. And I don't think it's as much of a technical issue as it is a people and an ownership issue. It's more intellectual than it is technical. 5 years ago, it was technical too, but I think we've crossed the boundaries of the technical pieces. So what can industry and academics bring? Well, I have a bit of a laundry list here, but they do come around the areas of systems integration, around IT architecture design. There are so many times when I talk to people, both within the organization that I'm a board member on and other hospitals, they have no idea how in the world they're going to link all this stuff together. Because it's somewhat complex, and they may or may not have the training around the architectural design piece, and how to fit old and new together and do it at a reasonable cost. The multimedia tools and configurable knowledge tools, how they fit into the system, where they fit, and how they can be updated in real time. And all the technical tools that go with the new technologies. Involvement of the users and providers in coming up with a solution that works for everyone, and that in itself is a big job and a big task. The reimbursement incentive schemes being another key area around partnerships, working with government, developing flexible funding for information management, and also being able to look to both the short and the long term, because short term I don't think gives you the same kind of reward as looking at the medium to long term effects. And the last piece being accountability and responsibility around data ownership and privacy, working with government and legal counsel to frame the issues and solutions that are there, and then coming up with a going forward strategy. Seems to me that partnership and working together is about the only way this is likely going to be resolved in the near term, and I'm thinking of that being the next 2 to 3 years. Thank you.
Our next speaker is going to give 5 minutes. So I welcome Patricia.
Good afternoon, I'm Patricia Berta, working for MyTradeVision, a company that works in the field of medical imaging, visualizing impacts, and integration for radiology departments, as well as imaging technologies beyond that in other imaging demanding areas, as well as information demanding areas. So I'm going to bring a little bit of a perspective from an industrial point of view, though you will see that a lot of these themes are, the world is what it is, and the view on the world is the same whether you look at it from an industrial perspective or from a healthcare perspective. You face the same challenges, basically. And I'm going to start with a kind of optimistic view, since I'm an optimistic, is where would we like to be? Actually, we all think of a situation where all of the various stakeholders in healthcare would be connected through some framework that enable them to communicate freely and have each single individual healthcare stakeholder, doctor, physicians, patient themselves, being able to access the patient record, being able to access any data on about that patient across his lifetime, or from a managerial standpoint, being able to access information that enable a better and more efficient management of all of the infrastructure that have to be managed, of their scarce resources and that type of things. Now, this is where we would like to be, and we all know of scenarios like being a doctor, like a neurospecialist at home, and being paged on your wireless PDA because a patient has been entering the trauma room for some neurotrauma, and basically from your PDA you just get you get some patient information related to some allergies that this patient has. As you drive to the hospital, you're just able to pull from the packs the MRI images that have been done from this case, get some priors. you see that there is a very rare disease that this patient has, and you just want to talk to a specialist who's in the UK, and off you go with your computer and get all of the patient that you want, the patient information you want, and some reference to other site, talk to an expert. Well, all of these type of scenarios are things that we all have seen, some rare examples or some science fictions even. But as Chris was mentioning, this is not really where we are today. Today we have a very fragmented system, a very fragmented healthcare environment with a lot of disparate systems, disconnected systems in various silos, and a lot of challenges for people trying to take care of the patient care, or for people trying to manage the institutions and the infrastructure to do their job efficiently and access the information they need to do their job. Basically, today's reality is or starting to use IT not to the level that would be needed. We've talked about the underfunding, and that definitely has an impact from an industrial perspective. For instance, from the level of investment that you can do also as a supplier to be able to support all of the needs. Now, the good news is that more and more standard technology can be used, such as web, internet technologies, that help moving forward into addressing all of these needs. So things are converging into the right direction, but we still have a lot of challenges, and in fact it's very, very difficult to create unified views for the users when they want to have them in real time of the type of patient data that they would need, or managerial information data that they would need in order to make the right decisions, for instance, as a board member. And so, in terms of a number of challenges that we encounter in today's reality, and a number of them have been outlined already, you have some basic technical issues that need to be addressed before we move into this holy grail type of situation, where basically you need the various institutions, the various physician offices, even through to the patient if you have home care, to be properly connected so that they can access through the computer system or any other information technology infrastructure the information where it resides. So we still face a lot of bandwidth issues, performance issues, not being able to pull the record at the speed that we want, or just not being connected at all. As we want to create longitudinal patient records, there is, of course, a need to be able to access the information and to be able to store it. So increasing demands from a storage perspective that needs to be addressed. The reality in the various institutions, of course, is that you are working in one single institution with a number of different systems from different vendors. Again, silos, a lab system that doesn't talk to the radiology system or to the cardiology system, even though you would like to be able to pull that lab information from any of these places. So different systems, different technologies, hard to connect still. Large number of legacy systems, Chris alluded to that before, that are based on older technologies that are more complex to integrate or to deal with, to pull the relevant information. And some very basic problems. If you want to be able to have the patient records move together with the patient, well, you have very simple issues like being able to address the patient ID in a unified way, basically. In the various facilities that the patient will have been physically going into, he will have a different patient ID, and just the reconciliation of these different patient IDs is a complex problem from an industry perspective to just be able to solve. In the PACS world, for instance, if you think of hospitals that just try to come together and share PACS image records from the patient, and if the patient has exams from different institutions, just the simple fact of not being able to access that information because you don't know the identification of that patient creates some challenges. And that also relates to basic interoperability between the various systems, also from a technology standpoint. As we move into integration, into building integrated view of patient records, definitely some, and providing access to the information to a larger number of stakeholders. Issues around security, privacy, making sure that only authorized people will have access to the information. remains also one of the practical challenges that have to be resolved today, and where also regulation can help or can be another roadblock on the way of getting towards integrated IT infrastructures. As part of today's challenges, again mentioning disparate systems, not connected systems, the more islands, fragmented systems you have, the more silos you have, the more difficult it is to just keep up with all of these infrastructure in a way that it's easy to service and to maintain. Basically, the more fragmented, the more complex to keep up with. And all that leads to situations where people are challenged with, again, these silos, these fragmented approaches, not accessing data, and all of the complications or all of the drawbacks that can result from that related to, for instance, medical errors, simply because you haven't been able to access the lab results or you haven't been made aware of an allergy. You're going to order the wrong drug, or you're going to order an inappropriate procedure for the patient. And actually, medical error seems to be a topic that is getting a lot of attention these days. The Institute of Medicine published a study in '99 whereby they showed that around 98,000 people in the USA were dying every year due to medical error. So there is a huge challenge here, and also an area of improvement where IT can definitely help. All this, related to the fact that it's very difficult through this type of fragmented and siloed infrastructure that we have today to just understand clinical outcomes. How good is the care that we're providing? Well, if you can't access the information, you just can't monitor these things, and you don't really know, and you can't improve, and you can't manage the change. It's a kind of chicken and the egg and snowball effect here. And you also are challenged to manage your scarce resources, as was mentioned earlier, and just optimizing the workflows to provide care in a way that you use your resources in an efficient way. So, today's reality, the list of challenges, I think, is very long. One of the big challenges that we also emphasized, and I think, as I was saying, all of the themes will probably be very common amongst all of our presentations, because we all face the same reality. One of them being the shortage of trained professionals, and basically being able to have people or IT professionals within the healthcare institutions that can use and that can maintain and monitor the IT infrastructure and the clinical information systems or other information systems that are out there. And that's where definitely cooperation with academic centers, making sure that training program, education programs grow, can make a big difference in the future. We've also alluded to the fact that the lack of financial investment or the way the money is directed is definitely a big challenge here. 2%, 1.6, 1.8, whatever the actual value, it's definitely way below what we need in a very information-demanding industry like healthcare. And all of this being in a world that is ever-changing with consumer and patient expectations that increase. Basically, patients live in a world where they're able to do a search on the internet and in a fraction of a second have access to a complex set of information, can communicate with one another, get access to services in a wireless fashion. And it's kind of hard for them to understand that the doctor cannot just access to a few textual pieces of information related to the lab results from the exam he had a year ago, and has to have a second lab exam for exactly the same thing, even though a recent one was made, and so on and so forth. So basically, the expectation and the level of education of the consumers is definitely increasing, putting the bar higher from an IT perspective for healthcare as well. So managing all of these changes is definitely one of the important ongoing issues. And so what kind of strategies can we think of to help addressing all of these challenges, the difference between the Holy Grail and today's reality? Well, basically, it all starts with simple. Just define your goals and have a clear set of objectives and a corporate strategy that includes IT, and that is going to be leveraging IT to achieve a number of business goals. Now, because today's situation with the siloed, the fragmented approach that we've already described is so far from the goals that we would like to achieve, basically, common sense just provides an indication that having a stepwise approach, having a roadmap with a growth path that is very progressive, makes a lot of sense to just be able to move progressively towards the wanted approach. And so start from the ground up. As long as there is no basic infrastructure, no network connections, no PC at various desks, as long as there is no storage infrastructure, not much is going to be able to, we won't be able to have much happen in terms of building more complex computerized patient records or decision-making type of systems. So basically, build an infrastructure, make sure that for various clinical specialties, the workflows will be integrated, leveraging standards as much as possible. Here, an example is given of a standard that is emerging and taking more and more importance in radiology, which is the integrated healthcare enterprise. Basically, and we have specialists in the room from that perspective, but basically what this standard does is, on top of standards like DICOM or HL7 that indicate how you're going to transmit information from one system to the other, this technical framework provides an indication of how the various systems should behave with one another. So the system where the order is placed, the order placer, there will be a certain set of rules on how it should communicate with an order filler, with an image acquisition device, just to make sure that the workflow is going to be smooth from the moment the order is made to the moment the acquisition is actually taking place. The images and the information related to the procedure are pushed back to the various information and image management systems. And so basically the integrated the healthcare enterprise not just gives technical protocols but also addresses real-life situations. The regular ones, like scheduling a patient, having the acquisition and making sure that the report is going to be available in the various systems, but also exception scenarios such as trauma cases where a patient comes, is immediately transferred into the X-ray room, is entered as John Doe into the system because you just want to image the patient, you don't want to take care of getting the images from the radiology information system. And as you have a John Doe on your image acquisition device, and you have the actual patient name on your hospital information system where you need a reconciliation mechanism. And the IHE technical framework also provides guidelines for vendors to hook up their systems in the appropriate way to be able to support such real-life scenarios. So basically, managing workflows of various departments such as radiology, cardiology, and so on top of a basic infrastructure that you've built, and then going into more complex type of applications, and introducing more complex knowledge-based type of systems, introducing decision supports, for instance, providing guidance in a physician ordering entry system for the doctor to be able to be alerted if there is an allergy on a contrast medium, if the patient has to go into a CT exam with contrast. Adding that type of intelligence with the system is something that can be done on top of more basics infrastructure. Basically, you can't build intelligent system on top of chaos, so you just need to do things in a stepwise and logical fashion. And again, in terms of ways to improve the system from the existing challenging situations, partnership between the industry and academic centers can be of a great help, not only to ensure that the level of awareness, the level of education, the training of the various players is going to be improved, but also to work together on some advanced technologies or advanced systems that can be of benefit. And maybe Dominic will be able to comment a little bit on what we're trying to do at the university. Okay, so I'm going to just step very quickly through these because they're kind of the same approach of building a step-by-step infrastructure, making sure that at least the silos are very well integrated among themselves, for instance, smooth integration within radiology, cardiology, etc. Wrapping legacy systems that can be challenges, and then building an infrastructure where things get connected, adding clinical workflow management, adding some extra level of intelligence like taking care of patient care pathways, and decision support. And basically, as you increase the level of infrastructure complexities, you are just able to access different level of data to information to knowledge, basically. Number of success factors. Some of them also have been mentioned. Again, I think the point of view from a healthcare perspective or an industry perspective just converge. But I guess it's very important to make sure that all of the stakeholders share the same long-term vision. There's no way that we will get there if there is no consensus of what we want to reach. And that requires collaboration between government bodies, a number of vendors, because the world is always going to be multi-vendor, and hospitals. Deploying a step-by-step approach with a progression in terms of the level of complexities of the information management, basic infrastructure, managing workflows, and then adding some intelligence such as decision support, care pathways, etc., etc. As we mentioned earlier, the human factor and the human resource issues are really key to be able to address all of the challenges that we're facing in healthcare IT. And basically, the world is changing. We are using technologies that is evolving. We're trying to gradually and in a stepwise fashion improve the level of integration in the healthcare infrastructure. But all this goes through change management, and people, for instance, in the example of implementing a PACS in the radiology department, it just requires complete adaptation of the processes in the department and making sure that the whole staff is going to be able to work according to the new method. So again, training and HR management issues. And I guess that will be a number of items that have been mentioned that are where we see shared challenges and need for collaborations amongst academics, vendors, hospital institutions, governments, to just get us moving forward.
Just pass on the mic to Nick Sircone. Nick is going to give us an academic point of view, academic and research point of view.